Physiowebseries Shoulder Complex Season 2. Let's begin with Series 3. In Season 2, we are covering shoulder musculature, muscles attached to shoulder joint or shoulder girdle. In Series 1 and 2, we covered the rotator cuff muscles. Now continuing with Series 3, where we will learn about scapulothoracic muscles, as the name suggests, the muscles which are attaching the scapula to thorax. So, scapulothoracic muscles, we have two, pectoralis minor and serratus anterior. Starting with pectoralis minor. Origin of pectoralis minor is from 3rd, 4th and 5th rib near the costochondral junction. Originating from here, it will insert to medial surface, medial border and upper surface of coracoid process. So from 3rd to 5th ribs, it will start and go to the coracoid process. Now let's see about the nerve supply. So the pectoralis minor muscle, which can be appreciated over here, is supplied by this medial pectoral nerve, which comes from medial cord of brachial plexus. We can see how the brachial plexus passes beneath the pectoralis minor muscle, and from there only, from the medial cord of the brachial plexus, medial pectoral nerve is given to pectoralis minor. The nerve root for this medial pectoral nerve will be C8 to T1. So medial pectoral nerve innervates the pectoralis minor muscle. Moving on to action of pectoralis minor. So as we know, from the ribs, 3rd to 5th ribs, it goes to coracoid process this way. So this is the insertion. So this is the point of insertion of pectoralis minor muscle, and as we can see here, this red arrow marking how the line of action is working in this manner, downwards, pulling the insertion down. So we can understand that it is attached to scapula, coracoid process of the scapula. Hence it draws the scapula forwards, or it does the anterior tilting of the scapula or protraction of scapula. So this one important function or action of pectoralis minor will be that it draws the scapula forwards with serratus anterior. That is, it brings about protraction or anterior tilting of the scapula. It also depresses the point of shoulder as it is working in this direction, and also it assists in forced inspiration. So that was about action of pectoralis minor. Now as we know that the brachial plexus and other thing is subclavian artery, can be also appreciated over here. So this structure is passing beneath the pectoralis minor. So if there is tightness in pectoralis minor, then it may cause compression of this neurovascular bundle. So what pathology can occur? Let's discuss about that. So the neurovascular bundle and the C5 to T1 brachial plexus, that is in short the brachial plexus, and the subclavian artery, which is the neurovascular bundle beneath the pectoralis minor muscle. We can see here subclavian artery and vein, and the brachial plexus is passing beneath this pectoralis minor muscle. So if there is sustained contraction of this pectoralis minor muscle, then there will be compression of those neurovascular structures passing beneath it. That is, we can see over here thoracic outlet, compressed area. So this is the thoracic outlet, that from the thoracic region there is this outlet for those neurovascular structures. So if there is sustained contraction of this pectoralis minor muscle, it may lead to thoracic outlet syndrome, TOS, or thoracic outlet syndrome. Other than that, if there is sustained contraction of pex minor or pectoralis minor, there is tightness of this muscle, then it will pull the shoulder this way The protraction of scapula, action of it is protraction of scapula. So there will be forward shoulder position. So forward shoulder position or drooping of shoulder that may be seen due to tightness of this pectoralis minor. Other than that, there may also be dysfunctional breathing pattern because of overcontraction of this pectoralis minor muscle, as it also helps in forced inspiration. So pathology in that can cause dysfunctional breathing patterns, thoracic outlet syndrome, then forward shoulder position, and the third thing is dysfunctional breathing pattern may occur if there is sustained contraction of pectoralis minor. As we know that neurovascular bundle passes beneath this pectoralis minor, which can be well appreciated. The brachial plexus and the subclavian artery and vein, all these structures are passing beneath this pectoralis minor, which is arising from third, fourth, fifth ribs near costochondral junction and going to insert to coracoid process. So the tightness of this muscle is causing those problems. So how to test the tightness of pectoralis minor? Let's see that. So the patient, as seen in this diagram, is in supine lying and the arm or shoulder is forward flexed to 30 degrees. Now what the examiner does, examiner places the hand or the heel of hand over the coracoid process, which is the insertion of pectoralis minor muscle. So over there, examiner will place the heel of hand and will push it downwards, that is towards the table or downwards, trying to retract or in order to retract the scapula, opposite to the action of pectoralis minor, which is protraction. The action of pectoralis minor is protraction. So the examiner is trying to do the opposite action to that, so that we can come to know about the tightness of the muscle. So normally what will happen, this posterior movement or the retraction will occur with no discomfort to the patient. Patient will allow it to happen, and the scapula will also lie flat against the table. But if there is tightness, then there will be some restriction, some barrier observed by the examiner, as well as the patient will also get muscle tissue stretch of that muscle over the pectoralis minor during that posterior movement which the examiner is applying. In that case, the test will be considered positive, that is, there is tightness in pectoralis minor muscle. So that was a simple test conducted to check the tightness of pectoralis minor muscle. And if there is tightness, we know the pathology part. It can cause thoracic outlet syndrome, important one to remember, as the neurovascular bundle, the brachial plexus and the subclavian artery is passing beneath this pectoralis minor muscle. Other than that, forward shoulder position and dysfunctional breathing pattern may also occur. So that was about pectoralis minor muscle. Next, moving on to serratus anterior. So serratus anterior, where does it originates from? It will come from upper 8 ribs as 8 digitations. So it will come, as can be appreciated in this diagram. So origin is from upper 8 ribs, as it gives those 8 digitations which are in mid-axillary plane. So in this diagram also, this is the lateral view, so that we can appreciate the origin and insertion of this muscle. So it is present in mid-axillary plane. So it arises from upper 8 ribs plus the fascia covering those intervening intercostal muscles. So mainly from upper 8 ribs. And then it will insert on scapula, but where? Medial border of the scapula, and that to the costal surface. So here in this diagram, we can appreciate the posterior surface, but we have to imagine the forward portion slightly marked over here. So the costal surface actually of the scapula along its medial border will be insertion of this serratus anterior muscle. So coming from upper 8 ribs going to costal surface and medial border of scapula. That will be the insertion. Now considering the digitations as they are divided, the first digitation will go where? To the superior angle of scapula to root of spine. So it is divided, like the first digitation will go over here, we can see, from superior angle to the, so can be appreciated well now. First digitation will be inserted from superior angle of the scapula to the spine of scapula, root of spine of scapula to be more specific. That was about first digitation. Other than that, we can see digitations on the medial border. So next 2 or 3 digitations will be inserted on the medial border of the scapula, and the lower 4-5 digitations, 4 or 5 digitations, the lower ones, they will occupy this. We can see here the large triangular area over the inferior angle of scapula. So this is the inferior angle of scapula, and this large triangular area will be occupied by lower 4 or 5 digitations. So the upper one digitation from the superior angle to the root of spine of scapula, then next 2 to 3 digitations to the medial border of scapula, and lower 4-5 digitations covering this large triangular portion over inferior angle. That was about origin and insertion. Apart from that, the nerve supply. So we can see here nerve to serratus anterior is long thoracic nerve with nerve roots C5, C6 and C7. So this will supply the serratus anterior, can be appreciated over here in yellow color. So that is nerve to serratus anterior, long thoracic nerve. Now let's discuss about the action. So serratus anterior, as we saw, pectoralis minor was doing protraction of scapula along with serratus anterior. We saw that. So the action of serratus anterior is also scapular protraction mainly, which is pushing and punching movements. And because of that, it is also known as boxer's muscle. So serratus anterior is known as boxer's muscle. It does scapular protraction. And also one more important thing, which is the function of the serratus anterior muscle, is it will steady the scapula during weight carrying. So when the shoulder joint is loaded, the scapula needs to be steadied in order to carry out the movement optimally. So the steadying of the scapula will be done by serratus anterior muscle during weight carrying. Other than that, this also will help in forced inspiration as the pectoralis minor muscle did. And one more thing, the fibers which are inserted to that inferior angle of scapula, as we saw, the large triangular area over inferior angle, lower 4-5 digitations were inserting there. So those will pull the scapula forwards and will rotate the scapula in such a way that glenoid cavity of the scapula will be turned upwards. So during movements such as abduction, flexion, when the glenoid cavity also need to be oriented or aligned in a specific manner, so the scapula will be steadied by this muscle, and also the glenoid cavity will be turned upwards mainly by the lower 4-5 digitations which are inserting on inferior angle of scapula. So this part will be pulled forwards by those fibers, and the scapula will be rotated such that the glenoid cavity will be turned upwards. So those things about the action of serratus anterior. It is the boxer's muscle. Scapular protraction is done by that. Steadies the scapula during weight carrying. Forced inspiration, so assists in forced inspiration. And the inferior angle of scapula, where some fibers are inserting of this muscle, will help to turn the glenoid cavity upwards during certain shoulder movements. So that was about the action. Now let's have a look at the clinical aspect. So as we know that the nerve supplying to the serratus anterior muscle was long thoracic nerve. So if there is injury, there is some pathology to this long thoracic nerve which is supplying this muscle, it may cause weakness or paralysis of this muscle, serratus anterior, weakness or paralysis. So because of that, winging of scapula may occur. In winging of scapula, the medial border of scapula becomes prominent when the patient or the individual is trying to do pushing or punching movement, which is prominently the scapula protraction. So to test it, there is punch out test. We can see in this diagram for serratus anterior weakness. So patient is standing and the arm is flexed forward to 90 degrees. Examiner is applying this backward force against which the patient is trying to perform the movement or resisting that movement. So if the serratus anterior is weak or paralyzed, then the medial border of the scapula wings. Classic winging will be seen. So over here also we can appreciate the long thoracic nerve supplies this serratus anterior muscle over here, and if there is weakness or paralysis of this muscle, then there is this winging of scapula, that is the medial border can be seen prominent. That is with scapula protraction, punching movement. Other than that, the patient will also have difficulty in abducting or forward flexing the arm above 90 degrees. So here we can see this is at 90 degrees, but above 90 degrees, as can be appreciated in this diagram. So above 90 degrees, the abduction or flexion will also be difficult with weak serratus anterior, but it may be possible. Still it may be possible because of the compensatory movement by lower trapezius. And also, to mimic this movement, we can also ask the patient to do a wall or floor push-up to find out the weakness or paralysis of serratus anterior. So this was about punch-out test and scapular winging seen in serratus anterior weakness. So that was about pectoralis minor muscle and the serratus anterior muscle, their origin, insertion, nerve supply, action, and added clinical aspect, so certain pathology associated with those muscles.